So a water's view is a X-ray that is taken for sinus, maxillary sinus. So you can see the maxillary sinus. Think about water and the sinus being full of water. Or you can also think of water, the W in water. You turn it upside down and it's an M, so maxillary. So water's maxillary sinus. Now the reverse towns, reverse towns is to see uh, the condylar neck fractures. Reverse towns is for condylar neck fractures. Remember how they say the neck of the woods, something like that. So think about where are the woods? In the neck of the woods, in the back of the town, in the back side of the town. Reverse towns, condylar neck fractures. And the oblique view is to see position of the mandibular third molars. Here you can see if they are lingually positioned or mandibular or facially positioned. Now, in complete dentures, what do they complain about? Lower is where they complain most about, and it could be many things. Possible dislodgement due to masseter, um, due to overextension of denture in the masseter area, masseter muscle. Also, it could be a pain due to impingement of the denture on the mental nerve or incisal nerve, or discomfort in the distal lingual because of the superior pharyngeal constrictor muscle is being irritated. Okay, so fentanyl. Fentanyl is fentanyl is a drug. Fentanyl is an opioid that is used as pain medication, and it can be reversed with naloxone. Naloxone or naltrexone. Naloxone is an opioid antagonist, and fentanyl is an opioid which is used for pain medication. It's also used as a recreational drug, often mixed with heroin or cocaine. Okay, so what do you use to reverse it? You use naloxone. Now let's see naloxone pretty quick. Naloxone, which comes also in the name of Narcan, naloxone. Naloxone or naltrexone. Naltrexone is another medication that is also used to manage alcohol or opioid dependence. So naltrexone and naloxone are different. So naloxone and naltrexone are opioid antagonists, and they are used to reverse a fentanyl. So naloxone, we're going to see a mnemonic for naloxone. We're going to see in pharmacology corner has a mnemonic about it, and naloxone and naltrexone. naloxone and naltrexone. So a quite simple but effective mnemonic for narcotic antagonists are uh, NA, 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 na na na. Narcotic antagonists are NA of narcotic antagonist, naloxone, and naltrexone. Okay, so naloxone, naltrexone. They can reverse fentanyl. Fentanyl is an opioid. Naloxone and naltrexone are used to reverse fentanyl. Fentanyl is an opioid. Next, um, for benzo overdoses, you can use flumazenil. Benzo, um, benzonatate, no, not benzonatate. Okay, let's look. Flumazenil can be used. Flumazenil Flumazenil is an injection that is indicated for complete or partial reversal of sedative agents of benzodiazepines in cases where general anesthesia has been induced, or to maintain uh, with benzodiazepines where sedation has been produced by benzodiazepines. So, flumazenil is used to reverse benzodiazepines. With benzodiazepines, you're going to find um, that are being used for anxiety or panic, for seizures, for insomnia, trouble sleeping, sedation, anesthesia, muscle relaxation, alcohol withdrawal or drug associated agitation, nausea or vomiting, depression or panic attacks. So these benzodiazepines are all different on how they start working, on how long they can work. For example, diazepam or Valium, they start working in 30 to 60 minutes. But there's all the Zepams, alprazolam, chlorithro, chlordiazep. No, well, I don't know about that one. But alprazolam, uh, oxazepam, alprazolam, diazepam, midazolam, Versed. So, for example, Versed can be used and it can be reversed with flumazenil. Now, let's read a little about flumazenil. Flumazenil, like I read, is indicated for complete or partial reversal of the sedative effect of benzodiazepines. So, midazolam is a benzodiazepine. Now, what happens when there is an atropine overdose? What can you use for atropine overdose? You can use pheostigmin. Pheostigmin. An atropine overdose can be um, recognized by its symptoms. So the symptoms of an atropine overdose um, will be, let me see, well, okay. Um, well, okay. I would have to look for that um, a lot more, but atropine, the side effects and the overdoses. Okay, so anyway, treat an atropine overdose, use pheostigmin. Pheostigmin. So pheostigmin is a drug that uh, is used to treat glaucoma, delayed gastric emptying, and it enhances the transmission of acetylcholine signals in the brain and can cross the uh, the blood-brain barrier. So it can be used to treat anticholinergic poisoning. What does this mean? Is that when there is a poisoning by substances that interfere with the transmission of acetylcholine signaling, like scopolamine or atropine, and other anticholinergic drug overdoses. It is also used to reverse neuromuscular blocking. So, pheostigmin um, is the antidote of atropa belladonna, which is atropine. Pheostigmin, it has been used as antidote. Um, so, yes, pheostigmin. And what can we see as a mnemonic for pheostigmin? The mnemonic, oh, so pheostigmin is pyridoxamine, pyridostigmine, pyridostigmine. So pheostigmine the most important part of about that is it's for treatment of glaucoma. It crosses the blood-brain barrier into central nervous system and treats atropine overdose. Okay, increases the endogenous acetylcholine. So pheostigmin fixes pheostigmin fixes atropine. Think about that. Now pheostigmin is seen on as medicine as pheostigmin salicylate injection. Pheostigmin contrasts atropine. So if you have too much atropine, pheostigmin. to fix it because it increases the cholinergic. Um, it increases the endogenous acetylcholine. So, okay, we're gonna see the next question. In a non-working position, and we're gonna see what happens in a non-working position. In a non-working position, the lingual incline non-working lingual the lingual incline of mandibular facial cusps. Let's see. Okay, this is important. So, working or functional occlusion, the occlusal contacts of teeth on the side to which the mandible is moved. This is a working occlusion or a functional occlusion. Is the occlusal contact of teeth on the side to which the mandible is moved. And it occurs when the facial or buccal cusps of the teeth meet with the facial cusps or the mandibular teeth, and the palatal cusps on the maxillary teeth meet the lingual cusps of the mandibular teeth. The relationship is not cusp tip to cusp tip, but cusp tip into cusp valley, with each maxillary cusp distal to corresponding mandibular cusps. So, working occlusion enables a person to hold and crush food. Now, balancing occlusion occurs simultaneously on the opposite side from working occlusion. Balancing occlusion functions is to maintain the denture in position during lateral excursive movements. So, non-working, the lingual incline of mandibular facial cusps. Yes. So if you are moving your right lower teeth, your molars, your number 31, for example, your 30, you're moving your mandible to your right. The contact that you're having is between the facial part of the facial of the vestibular cusp. So that is working with the palatal face of your facial maxillary. Okay, let's go over this 1 minute again. So let's go over this again. Um, so the lingual incline of the mandibular facial cusp. So the facial cusp and the lingual cusp. So the lingual incline of the mandibular facial cusp would be non-working if okay, I don't think this is right. So um, let's see an image here. We have an image here that we can see. Um, we're trying to find a good image because there's some that explain something different than what we're trying to see, but it's pretty straightforward. So now let's find something different. Let's see working. Movement. So the side toward which the mandible moves in a lateral excursion is the working side. And the not working side is that side of the mandible that moves toward median line. So this is the median line. The mandible is moving this way. So this is the working side, and this is the non-working side because the non-working side moves to the midline. Okay. We're going to see a quick video.
Video is going to be on occlusion, and specifically it's going to deal with occlusion and working movements. This lecture was put together by Dr. Burton L. Ranke, and I received permission from him to present this lecture, so just want to say thank you to him for putting this together and allowing me to present this. So the first thing we'll do is draw two rectangles, two large rectangles. One there and one right here. And this represents your maxillary teeth, you can see here. And then this rectangle is going to represent your mandibular teeth. And then you separate the rectangle according to the teeth here. So you can see we've got a canine here. This is going to be a first premolar, this is going to be a second premolar, a first molar, a second molar. And you can see that the we drew the squares or the rectangles off to represent the size of the teeth. So the molars are larger than the premolars, and then the canine has the smallest one. Alright, and then we're going to add some numbers now. Oh, and then this is lingual, this is buccal. Step 2, we're going to...
Okay, well, this is not going to show us what we need to see. But anyway, here, this would be the mandibular, the facial cusp of the mandibular, and this would be the lingual incline of the mandibular. So if the tooth is moving this way, which means it's a I'm confused.